So good morning again. This is Ray Walker with the Medicare Assistance Program at the Oklahoma Insurance Department. We welcome everybody to our last webinar. Thanks for joining us. Because we are getting started late because of these technical difficulties, I'm not going to spend a lot of time talking about other stuff. I'm going to go right into the presentation. And our topic today is going to be the Medicare current topics, and our speaker is Gay Humphrey. Gay works for the Centers for Medicare and Medicaid Services in Dallas as an outreach specialist and team lead for the local engagement and administration group. She has content expertise from over 15 years experience as a subject matter expert on Medicare program benefits. Gay is the local engagement and administration group's training lead and serves on the Medicare National Training Program Work Group. She is CMS Dallas's SHIP and SMP regional liaison, team lead for the opioid crisis outreach, and team lead for tribal outreach. The majority of her time is spent planning and implementing outreach and education events, as well as partnership and stakeholder development. Gay, it's all yours.
Okay, I'm trying to get all this extra stuff off the screen. Have y'all got 5,000 things on the screen?
No, what I'm seeing is just your presentation, but it's not in presentation mode yet.
I see that, and I am having a little trouble. Just a moment, please. I'm going to stop my video for just a second.
And while we're waiting, because I always forgot to remember, if you do have any questions over the course of the presentation, please chat those into the chat box in the lower right corner of your screen, and we'll get to as many of those as we can during the presentation. Any we don't get to, we'll get an answer to you afterwards.
Okay, full screen for participants.
Now it looks like full screen, but it's still not in presentation mode.
Okay, give me just one more second.
All righty.
I've got all this trash on my screen and I cannot get rid of it. If y'all are taking a nap, give me one more second. I think I'm feeling good about this kind of.
And now it looks like you've gone out of.
I know, I'm trying to get back in and see if I
Okay.
can't get this to work. Ray, I can't get up to the part where you share your, where you make it presentation mode.
Well, on the screen that I'm looking at, I see slideshow.
You do?
Yeah, up here at the top.
I've got 2 or 3 things stacked in front of it that I cannot get to go away.
And you know what, Gay? Are you able to advance your slides from where you're at?
Yes.
Like, in other words, if you went to slide 2, would you be able to?
Well, let's see. Some of this stuff. Okay.
Like what happens if you click on your down arrow?
Okay. Well, you know, you've got that little arrow inside the, let's see, page down.
Okay.
All
There you
right.
go.
Did that get it?
Yeah, that'll be good enough. I wouldn't worry about putting it in full screen. We can, the writing's big enough, we can see it.
Okay. All right. Well, good morning, everybody. I hope you've had a much better morning than I have, and your coffee was hot just like you like it, and your Diet Coke was cold just like I like it. So we're going to go ahead and get started today talking about updates to Medicare beginning in 2023. And you see here this first slide. It's saying, what are you going to pay for your Part B monthly premium? And you see, we do know that right now it's $170.10 a month. Well, the premium's going down a little bit, not a whole lot, but it is going down a little bit here to, of course, I can hardly see the screen, 164.50. Does that sound right to y'all? And so it went down a little bit because what happened with last year was it went up so much because Medicare had approved the drug, remember the new drug for Alzheimer's, and it was so expensive, but it come to find out they raised it too much, so they gave us a little break for this year. And we know that some people who get Social Security are going to pay a little bit less due to the hold harmless provision. And basically what that says is that the Medicare premium cannot increase more than a person's Social Security increase was. Well, this year we know in 2023 we do have an increase, but that's not going to change this 164 number. And of course, if you didn't choose Part B when you first joined Medicare, then you may have a penalty that you're going to have to pay. Or if your income exceeds a certain threshold, we know we call that IRMAA. And if your income exceeds a certain threshold, then you would have a higher premium for that. So let me go to the next screen. All right, now then, when we're looking at these screens again, what we want to focus on is the copay and for Part B. Ray, I'm going to have you help me because I cannot see the screen, that the part of the screen that shows me what the copay is. So can you help me with that?
I can. I just have to unmute my screen. So the deductible is $226, and then after that, of course, Medicare Part B is going to cover approximately 20%.
All right. Oh, look at this.
Oh, she found slideshow.
From current slide. Hallelujah. This is the best day of my life. Okay. All right. So you see that. So the deductible went down a little bit. It was $233, something like that. So the deductible has gone down for Part B. Of course, if you've used Medicare at all, you know that there's a $0 deductible for most of our preventive services. And they keep making sure that we mention this, but we don't have any disparity between what Medicare covers for physical health and mental health services. So it's still going to be the 20% coinsurance for mental health services and outpatient services and all that. All right. Now then, here's my friend Irma. We were going to talk about this a minute. If your income is now this is your MAGI, your modified adjusted gross income from 2 years ago. So if in 2021, your modified adjusted gross income, which is going to be on your individual tax return, if it was $97,000 or less for an individual, or $194,000 or less for a couple, then you're not going to have any surcharge added to your premium. But those people who have a higher income that's reported for 2021, you see the numbers here on the screen, and incrementally those numbers go up based on what their income was for that. Now then, you may say, well, in 2021, great, yes, I did make that much money, but I don't have, I'm not making that kind of money now. Well, this is appealable. Two things. You can appeal through Social Security. They're our contractor for Medicare enrollment and eligibility. And so they also assess the premium increases as well. So you would contact Social Security to ask to appeal this for you, because that's not the money that you're making now. So that would be the first thing. The second thing is, do not pay your premium for Part B, because you don't, if you're at that first bumped up level and your premium comes out at $230.80, if you just say, I'm not paying that until they get this straightened out, you could get disenrolled from Medicare Part B. And then we got a problem. So, Social Security will work that out with you, but please don't stop paying your premiums if you get assessed that amount. All right. So let's go ahead and go to the next slide. Right, yeah. All right. Now then, here are some things that are going to be happening. There's going to be enrollment simplification. Well, what's that about? Well, I'm going to tell you. There's a wave of Medicare coinsurance for certain colorectal cancer screening tests. Expanded access to mental health services through telehealth. We're all aware that telehealth has saved many lives over the pandemic, and it's going to continue to be a viable service for people for mental health services. And then extended coverage for people who have had a kidney transplant, so that they can continue to take the immunosuppressive drugs. So let's get into those for just a minute here. All right. Now then, certain colorectal cancer screenings, the cost sharing for patients is going down until finally in 2030, which will be here in 2 weeks. In 2030, Medicare is going to pay 100% of these certain colorectal cancer screenings. And then this year, Medicare is paying 80%. We're paying 20%. Next year through 2026, Medicare will pay 85%. The copay will be 15%. And then 2027 to 2029, Medicare will pay 90%, and the beneficiary will pay 10%. This is like they did with Part D with the prescription drug coverage, as far as, what you paid for your medications and the donut hole, and how all that finally worked out. So just something to know, that those costs will go down. Now, why would they do this? We want people to get that colon cancer screening. All right. Mental health services, I'm just going to tell you, it's going to continue for mental health services furnished on or after the first day after the end of the public health emergency. So when we are given this 3-month notice that the public health emergency is going to end, once it does, then telehealth will continue to offer services, mental health services for that. Kidney transplant patients. Many of you know that Medicare covers children as well as adults. And the reason Medicare covers children is because Medicare provides services for any age person who is on dialysis. They're waiting for a kidney transplant. They have what we call end-stage renal disease. Well, once a person has had that kidney transplant, for 24 months, Medicare will continue to cover their expenses, Part B expenses. What's going to happen now, though, is that coverage for the immunosuppressive drugs will stay in place. So these people who do this, regardless of their age, can stay with Medicare, for Medicare to pay for this immunosuppressant drugs until that time frame has ended. At that point, then you see we've got 36 months. I said that backwards. We've got 36 months, and then after the month, 36 months after the month of the transplant. So Medicare will continue to cover that. There's a modified Part B set aside for them. The premium is less. They won't get any other services, and only the drugs that are immunosuppressive drugs will be covered, but Medicare will continue that. And this begins January 1st of next year. All right. There's not a specific enrollment period. It's only the immunosuppressive drugs, as I said. The insured person cannot have any other kind of insurance. If they didn't have Medicare, they would have no other way to get insurance coverage for this. The premium will be less, as I said. And also people that are eligible for the Medicare savings programs, the help paying for their Medicare premiums and things like that can receive coverage for the premium and cost sharing as well. So it's not just the one or the other. Both of those would work together for that person. All right. There's a 5-year voluntary enhancing oncology model. It's just really to enhance the quality of care that someone gets while they are receiving, cancer treatment. So some of the things they might get would be an appropriate clinician available 24/7. Now, it's not going to be the same one. People, different staff will take that coverage, but you have real-time access to medical records. All of that will be available 24/7. Of course, there would be a detailed care plan, and also social work type services. We'd see, does this person need help with meal delivery or transportation, housing even? So those are all parts of that as well. Now this begins next July, so we've got just a little while. It's a voluntary thing, so people who are receiving cancer treatments will get the opportunity to volunteer to do that if they would like to do so. So let's look at what's new for Medicare Advantage updates. Well, we know, and we've already talked about this, about the oversight of a Medicare Advantage plan, marketing and communications. So I'm not going to really go into this too much, but what we're trying to do is make sure that we strengthen the oversight of these plans. So what they market and communicate about the Medicare Advantage plans is up to Medicare standards. And if it's not, then there would be sanctions that could be assessed against either the person who's giving the wrong information or the plan. The plans are also charged to ride herd better. Isn't that a good old Texas girl term? But to ride herd better over the agents and brokers that are representing the plan for them. There's great things on the website about how to appoint a representative if a person needs someone to assist them and have legal rights to do that. Enrollment, instructions and forms, all those things would be on the website for the plan. All right. Access to care during disasters and emergencies. Medicare Advantage plans have to abide by the access to care rules when there is a disaster or emergency. These would be disasters or emergencies that are declared by the federal government, the state government, and maybe local government. However, in Oklahoma, if there is a really bad storm up in the Tulsa area, and it is just, it shuts things down. But down in southeast Oklahoma, there's no big storm. Maybe they got a little bit, but it didn't shut things down. Well, in southeast Oklahoma, they can't say, "Oh, there is a special enrollment. Let's get out here and get busy and get some new clients for our plan, and we'll base their enrollment on that storm that's up, in the Tulsa area." Well, that can't happen. Local means local. It doesn't mean all over the state. So just be aware of that as well. And there are requirements that the Medicare Advantage plans provide services and coverage, and that may mean out-of-network coverage that the plans would go ahead and cover while that disaster or emergency is still active. All right. Plans have to have an adequate network. Nothing's worse than getting a plan and going to your doctor and the doctor says, "Oh, we don't take that plan." So we want to be really informed consumers to make sure that our providers are on the plan that we're interested in looking at. And then also we want to know that the plans have rules that they have to have an adequate network to serve the folks. All right. What about Part D updates? Are there any updates for Part D? Well, IRMAA applies not only to your Part B premiums, but for the Part D premiums as well. And you see the income levels are the same as they were for the Part B premium. And with these, you get an amount tacked onto your plan premium. So whatever the plan premium is for your prescription drug coverage, based on your income from 2 years ago, it's the whole same process again for Part D as it is for Part B. It's just structured a little bit. And the money that is collected for this IRMAA, for this increased income, has to do with the fact that those people who have more than are asked, not asked, they are required to pay this IRMAA unless they get an appeal for that approved for them. But the money does not go to the plan. The money goes to the Medicare Trust Fund. We're just trying to sustain the Medicare Trust Fund as long as we can. And this is one way that we are able to put money back into that fund. That's the fund that pays all of our Medicare expenses. So, and we've heard for years, that things are not looking good with the Medicare Trust Fund. So we're just looking at all kinds of ways to increase that fund so we have coverage for as long as possible. Beginning January 1st, there's going to be a real-time tool that drug plans can offer or will offer to look and see exactly, okay, my doctor prescribed this medication for me. When I get to the pharmacy, what's that going to cost me? Is there another drug that might cost me less? Can I look at a different pharmacy and see if they have it priced differently? But that really will help avoid a lot of sticker shock as you're standing at the pharmacy and they come back and say, all right, that'll be $372 today. That's not good. So we need to know when we're going to the pharmacy what those medications will cost us. So this tool will be provided by your drug plan, your Medicare prescription drug plan. All right. I flew through this information. Here are some good websites for you, and I'll get this information to Ray as well so that he can send it out to you. Here are acronyms. I try so hard not to use acronyms because we got a million of them. And sometimes the same one is used for 2 or 3 different things. So this is just a glossary, really, of acronyms that Medicare does use. Here are just a few more. And that took us through the whole PowerPoint. So let's look and see if we have any questions that need to be answered. Okay.
Thank you. Okay. First one, you were talking about the changes related to preventive services, specifically the colorectal cancer screening. So yes. I just wanted to make sure, because someone was raising a question, currently the colorectal cancer screenings are covered at 100%, but the challenge was that if the doctor found a polyp, then it immediately became diagnostic. And that's where people were getting upset because, let's face it, in the middle of a colonoscopy, you're not really in a position to make a decision about whether you want to keep going or not. So that's what created this push to get it covered at 100%, regardless of whether the doctor found something. As long as you had never been diagnosed before and it started out as screening, that's what their goal is to get us to that point to where people they don't have that surprise when they wake up, So, did I say that right, Gay?
That was real good.
Okay. The second thing, on the immunosuppressive drugs for people who have end-stage renal disease, they have ESRD Medicare, so it's just Medicare because of that ESRD diagnosis, and then they have that successful kidney transplant, but they still, like you said, the immunosuppressive drugs, they only pay for them for 36 months after the successful kidney transplant. the continuation, this new process that we're talking about, I put in the chat that the premium for that would be $97.10. And that only provides coverage for those immunosuppressive drugs. It's not the other health stuff for Part B. It doesn't give them full Part B coverage. It basically just covers those drugs. Is that correct?
Yes, that's exactly
Okay.
right.
Now, did the person have to, uh, I know there's certain criteria for the drugs to be covered by Part B, such as where the person had the transplant and did they have Part B at the time of the transplant and all that stuff. I'm assuming that person had to have met all of those criteria at the time of the transplant to qualify to have this Part B coverage.
Yeah,
This
for the
new change.
immunosuppressant. Yeah,
Okay.
sure. Yeah, because this is an automatic enrollment for people with end-stage renal disease who have had this kidney transplant, or they've just been diagnosed with end-stage renal disease. And once they've had the transplant, that all continues. All the services continue for 36 months.
Okay.
After the 36 months, then this would kick in.
Okay.
Or as long as they need those drugs.
Okay, but I'm assuming that they would still need to, because I know that in the CMS information it emphasizes how important it is that people who qualify, they may have started out on ESRD Medicare, but for some reason now, because of disability or age, they now qualify for traditional Medicare. So they need to go ahead and go through that enrollment process so they don't have any kind of a lapse. So, all right, I am not seeing any other questions. You did a great job of covering a lot of information really fast. Angela Kane, I forgot to mention, also joined us. She's with CMS there in Dallas. Was there anything that you wanted to add or share with us?
No, I don't have anything to add. Thank you very much, Ray.
All
Ray, I
right.
saw a question pop up. Do you
Oh,
see
there
that
it
one?
is. So after the 36 months, do they no longer qualify for Medicare based on successful transplant?
Yes, that's right. After
Yeah.
the 36 months. But if they are still taking these maintenance immunosuppressive drugs, that's what qualifies them then for this model for end-stage renal disease.
Yeah, because those immunosuppressive drugs are expensive. And I believe, I don't have it memorized, the time frame to be able to stay on Medicare, ESRD Medicare, is 36 months following a successful transplant, but there's also a qualification that has to do with so many months after the last time you had dialysis. Do you recall what that time frame is? 18 months?
I don't.
I don't either.
I need to look that up. I don't know that for sure.
But if someone needs to know, shoot me an email. I'd be happy to look that up for you. And we talk about it in the training and stuff, but we only added that module, I think, last year because we were getting a lot of questions about it.
Yeah.
But I can find that information for you if you'd like. All right. If nobody else has any questions, appreciate everybody joining us. Gay, thank you so much. I know this has been a rough morning for you, trying so hard to get everything connected. We have no control over the weather and what it does to our technology.
Obviously, I haven't.
What?
Oh, I was just going to say, obviously, I have no control over my computer. So.
The recording of today's webinar will be available on our website at oid.ok.gov a little bit later today, as are all of the recordings of the webinars we've done so far this year. Thanks to all of our speakers who helped us make this work and for the information that they shared to everybody. And want to remind everybody, we are in open enrollment now. Please don't wait till the last minute to talk to a counselor. There's a lot of good information out there, and we want to make sure that we take advantage of the opportunity to give you the counseling that you need. Also wanted to remind everybody, be cautious about the people that you're calling. Be cautious of the TV ads you're responding to. You just don't know who you're talking to on the other end of that telephone. Also, don't answer your phone. If you don't know who's calling, if it's important, they will call you back. If you do have any questions, give us a call at 1-800-763-2828. We'd be happy to talk to you. Also, you can send us an email if you prefer at MAP, that's MAP, at oid.ok.gov. So thanks again, everybody, for joining us. Hope everybody has a good day.
Thanks, bye.